Welcome to the lecture, recorded lecture for chest trauma. This is for Nursing 430. Here are your objectives for this particular topic. Please make sure that you review your objectives so that this will guide your studying. With chest trauma, there are different types of injuries that can occur. We're going to be looking at blunt and penetrating trauma. Blunt could be a result of a fall from a ladder, slamming into an object. Just simple falls can even cause it. A car accident with the airbag exploding can cause a blunt trauma. Penetrating trauma, I'm sure you can think of many examples of that. Stabbing, shooting, falling on an object that pierces through the lungs. The mechanisms of injury are important to determine because if it's a blunt trauma, you can't see how much damage has been done internally. The same thing occurs with a penetrating trauma. You can see the object went in. Did it fracture inside? Did it come out? Blunt trauma might be shearing of the other organs inside. You fall down or fall off a ladder or 6 feet from a building, something like that. And blood vessels, organs can actually shear away, which is going to cause very extensive damage. It doesn't look like anything has happened on the outside, but these people can die from this. Penetrating is actually the open wound, as we've discussed. Some of these injuries will resolve spontaneously. Others require pretty invasive treatment. Some of the treatments that we will be looking at will be a thoracentesis, chest tubes, and pleurodesis. If a pneumothorax, a collapsed lung, has occurred as a result of the trauma, whether it be blunt or penetrating, you may be in a situation where you have to do a needle decompression. Paramedics are taught this in the field. Doctors do it. Air-evac people will do it. As far as nurses doing it in a hospital setting, usually there is a healthcare provider, a resident and primary care physician, someone who can do it for you. Call the ER if no one is in the house and it's nighttime. It's a scary process. I've worked many outlying areas, and I had to do it one time, and it scared me half to death. We did have an x-ray to determine that there was a tension pneumothorax in the upper part of the lung, apices. We knew where it was. We could see it. We had assessed. We couldn't hear breath sounds in that area. The patient was in distress. It was on the right side. And as that lung collapsed, it would torque the heart a little bit, and we would see some dysrhythmias. So we had to act fast. There was no physician in the house. We did call, and this doctor talked us through the process of putting in a needle to allow that lung to slightly re-expand and stop the lethal arrhythmias, cardiac arrhythmias that were happening. Like I said, this is not something that you will routinely do. This was an emergency situation. We washed the chest area. It was up in the intercostal, and then took a large bore, I believe it was a 14-gauge IV needle, and we pushed it through the intercostal and took the stylet, took the plastic off and pushed the needle through. What happened is we heard a hiss as the air came out. The dysrhythmias went away. The doctor got there and put in a chest tube. Like I said, this isn't something that you will probably ever have to do in your lifetime, but it's an emergency situation, and it does happen in small outlying hospitals. Okay, rib fractures. I wonder if any of you have had them. They hurt. Oh boy, do they hurt. They're the most common in ribs 5 through 9. They're bones. They're thin, bones. They fracture, and when they fracture, they bleed, of course. Bones bleed like terrible. But those sharp edges can go ahead and be moving. They can actually damage that pleural sac. They can pierce the lungs. Depending on where it is happening, it could even stick into the aorta, the vena cava, or the surrounding internal organs. What does a patient look like with rib fractures? Well, they're in pain. I'm here to tell you, and they will not take a deep breath for you. They will not. It hurts too much. They are sitting very, very still. They will usually put their arm around their rib cage or hold a blanket there just so those bones don't move and the raw edges grate against each other. What can happen? Again, the atelectasis, they are not breathing deeply. Okay, atelectasis can lead into pneumonia. So we have to get things taken care of. That used to be the treatment that you would wrap the rib cage so those bone ends wouldn't grate. We don't do that anymore. Can you think about why? They couldn't take a deep breath if their life depended on it if we go ahead and bind them. We do treat them with NSAIDs, reduced inflammation. We do treat them with opioids and nerve blocks when the pain is very severe. A lot of patient teaching. You're going to teach them how to get up differently. Yes, we want them to deep breathe and cough, not to heal the ribs, but to prevent the atelectasis and pneumonia. We will ask them to do an incentive spirometer, and we will medicate them. So how can you get this patient who is in pain because of the fractured ribs to cough and deep breathe and use EIS? Well, you're going to medicate them. We got that one. But let's teach them how to splint. Take a bath blanket, have it folded. Show them how to secure it against their rib cage so they can do the things that you want them to. Don't lay them flat. Let's get them up about 45 degrees when we're asking them to do this. Pre-medicate them before you're asking them to do these exercises. Now, flail chest is a whole lot of broken ribs. This person, you will look at them, walk in the room, they're not breathing well. The right side of their chest is going up and down, but not in unison with the left side of the chest. Something is very, very off. Okay, airway, ABCs, you know about that. We have to give them some oxygen. We will position them probably not flat, again, maybe like 30 degrees up. We will give them pain medication. And with the flail chest, they're going to go to surgery. Can we fix ribs when they're broken? Yes. It's nasty, it's messy, but they put little plates to put the ribs together. Sometimes they will even take a rib out if it's too fractured. But you have to get them ready for surgery. So think about all the things that you have to do now. They have to be NPO, or you have to know when they were NPO. This will be under general anesthesia. Allergies, got to know it. Get those IV lines in there. Get a panel of labs, CBC, CMP. Get some baseline ABGs. Let's get a chest x-ray. For sure, we're going to need that right away. Ascertain the amount of damage that was done. Are they on any blood thinners? What medications do they take on a routine basis? And they will go off to surgery to have an extensive surgery done by plating of the ribs, depending on how many are fractured. So how did they fracture? Was it a fall? Did an airbag go off? Do they have a history of osteoporosis? So boy, those ribs are very fragile. Lots and lots of things to get them ready to go. Some of the questions we'll have to answer later because the big deal here is get them safe. All right, here's your picture of your flail chest. The pneumothorax, you can see that happening. You can see that the raggedy edges of the ribs themselves and how they could cause all kinds of bleeding. The diaphragm is probably not moving well. Their breathing pattern is very, very irregular, and they are in severe pain. Do you think this is kind of an emergency? I would think so. All right, so with chest trauma, respiratory distress, first thing. Are they short of breath? Is it difficult for them to breathe? Are they coughing? Are they coughing up blood? Cyanosis, where do we look for cyanosis? Oral circumpellar. Fingertips. Do they have tracheal deviation, or otherwise known as tracheal shift? Or is it midline and straight? Hopefully so. What are their breath sounds like? What is their O2 sat? If they're coughing up frothy secretions, that means that we have even more extending damage. Heart failure. Take a look for cardiovascular compromise. What is their pulse? Is it regular? Is it rapid? Is it strong? Is it thready? What is their blood pressure? Do they have a narrowed pulse pressure? Is the right arm different than the left arm? What are their neck veins? Are they distended? Are they flat? Can you hear their heart sounds? Are they clear? Can you hear S1, S2? Are they sharp? Are they complaining of chest pain? And what is that EKG looking like? If they have a pneumothorax on the right side, they may have cardiac dysrhythmias very quickly. So our interventions are very, very important here. Make sure that we have circulation. So I would suggest that we are going to start an IV and have fluid on the ready. They may have to be type and cross-matched for blood. We may have to give a transfusion. Okay. What do they have a patent airway, or is that trachea in trouble? And are they breathing? Oxygen, how much? We want to keep our stats greater than 90%. So you will look at that and say, oh, nasal prongs are at 6 liters. It's not helping. I better go to a simple mask. Oh, now it's 91%. Still not where I need, maybe where I want to be. Do I need to go to a non-rebreather? Do I need to go to a Venturi mask? Or are we going to have to intubate this person? You want 2 large bore catheters. That means that it's not going to be a 22 gauge. You want a 16, an 18, minimum of a 20. This person is probably going to end up with a central line as well. Take the shirts off. Check for other injuries. This is going to be part of your primary and secondary surveys. Now, cover a sucking chest wound with non-porous dressing and taped on 3 sides. Vaseline dressing is another name for that. Are you ready for a story? Here you go. They air-evac a young person in from the lake to the hospital where I was working. This kid, they had been partying on a boat in the lake. Somebody hit the gas to make the boat go. The kid flew out and landed on the propeller in the water. It sliced his ribs, his chest open. Somebody was quick thinking. They stopped the boat, they got him in, and they air-evac'd him out. He had a sucking chest wound. But you know what the paramedics did? They slapped a bandage on it, a Vaseline, large one, and so it wasn't a sucking chest wound for him. They intubated him on the scene and got him in. Okay, so now he has to have a thoracic surgeon to go in and take a look and repair any of the damage that was done. And boy, was there damage. Can you imagine in lake water, the water sloshing around inside the chest cavity with fish remnants and oil and everything else? This kid was headed towards sepsis in a big way. Okay, they cleaned him up, lots and lots and lots of antibiotics. They actually cut one of the ribs out and it was gone because they couldn't put it together anymore. He had a lot of other injuries, lacerations from being hauled up over the side of the boat, scratches. Infection was huge. He was also drunk. So you can imagine what the care was of this kid. Well, he did make it. He had respiratory problems, I would suspect, the rest of his life, but he did make it. He did have chest tubes that we will be talking about in a little bit for quite a long time. because of the infection and all the extra fluid that they put in. And so we monitored those very closely. He was on an EKG monitor, pulse ox, intubated to the respirator. We were worried about blood clots. So yes, he had a sequential hose on. He had a urinary drainage catheter. Boy, oh boy, were we worried about antibiotics, how many we were giving him and if his kidneys could be perfused or if we were causing damage. So you can imagine all the lab draws. So yes, he had an art line. You think this was a busy kid to take care of? Yes. Okay. Now on to impaled objects. Someone fell from a 6th floor window onto a spiked fence, and it went through them. And it broke it off, and he's laying there, and they bring them in. Do not remove the object. Do not pull it out. You're going to cause more damage. However, do stabilize it. What does that mean? Take a washcloth, a towel, anything, wrap it around the insertion point, and tape it down securely so that that impaled object inside the body cannot move anymore. The surgeon will take it out. Was that the only injury that this patient had? You better assess for all kinds of injuries. Did they hit their head? What are their pupils? Now it's time to get our full assessment in. With the chest, you're better to have the patient in a semi-Fowler's position or turn to the injured side unless they have an impaled object in there. You never move a patient until C-spine has been cleared. Did they fracture their neck? They'll be in a C-collar, usually if the EMTs bring them in. You do not remove that until you get the go-ahead. C-spine is clear. Yes, of course, we're going to be giving them pain medication, okay? And if they have a chest tube and they're out in the field, they're going to do that emergency needle decompression before they even bring them in. Okay, chest tubes and pleural drainage. We'll see them in the hospitals. You'll see them on the med-surg floor, ER, pretty much anywhere in the hospital. The purpose of the chest tube is to remove air, like a pneumothorax, or fluid, which might be empyema. It might be a hemothorax, and that's from the pleural space or the mediastinal space. People who have open heart surgery will have mediastinal chest tubes to drain the extra fluid that is collected around the pericardium. What we want to do is reestablish negative pressure when the body is breached. The chest wall, the thoracic cavity is breached. A hole in it, then the air shoots out. It leaks out like a high-powered squirt gun, only it's air that's going out. We have to stop that because the lung will deflate. Our deal here is to get that reestablish the negative pressure in the chest and get the lung to re-expand. Now, chest tubes come in all sizes, as far as length and as far as diameter. Are they small or are they big? 12 French to 40 French, 20 inches long, or they will have pediatric chest tubes. They will have neonatal chest tubes. So it's a good idea to have an idea of the size of your patient, okay? Do we put chest tubes in at the bedside? Yes, we do. So it is a nurse's responsibility to know how to set it up for the physician. You will not put the chest tube in, but you will have the equipment completely ready to put that chest tube in and know what you have to do to monitor it afterwards. Oops. Okay, chest tube insertion. They've identified that they want to go into this right side of the chest in the intercostal space. See the dots? Is this consentable? If it's an emergency situation, no, it won't be. If it is to drain empyema, which is pus in the lung, which has come from a very bad infection, they'll have them sign a consent. Well, the doctor washes the area. Get the arm out of the way, please. It's hard to go through it. They're positioned with the side up that they want to go into. Washy-washy with an antibiotic solution, numbing medicine into the area. What did you do for this patient before you even started? Well, You went and you got your chest tube insertion set. You got the size chest tube that the doctor wants. And guess what? You thought ahead. You brought 2 in case they drop it. You ask them what they would like to use to pre-medicate the patient and make sure you have a working IV. Let's have some oxygen on them. Let's put the pulse ox. Probably want to monitor their EKG while we're doing this. Washy-washy, numbing medicine into the area. The doctor makes a slight incision with the scalpel. The tray has been set up. You're sterile, they're sterile, everybody's sterile. They actually poke their finger into where they've made the incision, move it around just a little bit to try and make a track for this chest tube. Now, the chest tube is on something called a trocar. It's an aluminum, looks like a very long nail. And they use it as a guide. Or they will take a hemostat of forceps and a long needle nose, that's what that one is, and they will guide that through the hole into the space. Now, once we get it in there, we don't want that thing moving around. So they will actually sew it in place with purse string sutures. All right. If you take a look at this picture, you'll see that there are holes. Well, that's to collect the drainage, whether it be air, blood, or pus, and bring it out through that tube into your collection device. The collection device, they can be dry or they can be with water. But this collection device must be connected to suction. So part of your preparation was you made sure that there was suction in the room and that it worked. So you connected suction tubing from the collection device all the way up to the wall suction. There is a tube that comes out of this collection device, and that is where you will attach your chest tube. All right, the doctor has put it in. You connect it to the collection device, and then you have to tape that connection. You tape it in a spiral going up and a spiral going down. You don't want this thing falling apart. The doctor will tell you, put it to -20, -30, -40, whatever they want. And there's a little bladder in there, and as you dial up the suction, you will see it arrive at -20, -30, whatever the doctor has ordered. Okay, we're not done yet. Now we're going to put a dressing on. And we want this to be an occlusive dressing. So Vaseline gauze is one of those, and you put it around. Why? We don't want the air leaking back out again, right? Good. And then cover that with a gauze dressing and tape. Now your client is going to have some pain. Okay, how do we know it's working? Well, we're going to get the drainage out or the air out, but we want to look at repeated x-rays to see if that lung is reinflating or is oxygenation getting better because we pulled the fluid off. Watch your pulse ox. Doctor may ask for ABGs in a little while. Now, these chest tubes don't go in and out in 20 minutes. They are in probably for a long haul. So you need to keep an accurate output measuring of what is coming out into that collection chamber. So let's take a look at that. Here you can see the chest tubes going in and how it comes out with draining. This is something called a flutter or Heimlich valve. People actually do go home with these, with chest tubes, if they have continued drainage like pleural fluid. People who have cancer, kind of late stage cancers, will end up having all kinds of fluid collection around their lungs due to the cancer treatment or the cancer itself. So they will frequently go home with a collection device in place. They will be a very tiny, tiny chest tube that will be placed in, usually in radiology. The patient and or the family are taught how to manage it. Now, you see this side that says to patient, that's where this little tube coming from the patient's chest will go, and this manages the negative pressure. It's a one-way valve that opens only when the intrathoracic pressure is greater than the atmospheric pressure. We use this for emergency transport between hospitals, maybe in the helicopter or they're being air vac'd out, and for small to moderate sized pneumothorax. And I did tell you the other part where I've seen them given to end-stage cancer patients for pleural effusions. They allow the patient to be moved a lot easier, but these must vent to an attached drainage bag. And the drainage bag it looks like a big Ziploc bag. And you will empty that and record the output. Here's a picture of your bag. These are not comfortable. I'm not going to say that they are. So the patients will complain about them being in there, especially when they take a deep breath or cough. So you have to assess the site where it's going in, and make sure that you mark the location because these things can move. So chest x-rays, again, repeat ones, are a frequent occurrence. All right. With the chest tube drainages, we want to see, take a look at all the different chambers. Where's the fluid going in? Are we getting bubbling or tidling? Okay. Bubbling tells you that you have an air leak. Initially, when you put a chest tube in, you will have an air leak. It should decrease over time. If it has decreased and all of a sudden it comes back, then you have an air leak. That would be something you would want to notify the physician right away, get a chest x-ray, and find out what has happened. How has that tube migrated? Now, tidling, you will see in the tubing. You will see the fluid move back and forth, and it kind of goes along with their respirations. And it becomes less and less and less as that lung fully expands. Here is your chest tube drainage or container. Lots and lots of stuff going on. Atrium is a brand. There are many others out there. Take a look at the collection chamber. See, it has measurements on it. Now, do you notice in the right-hand corner, there's a blue clamp, and there is that's called a 5-way connector, that white thing. That goes into the tubing on the drainage container, the tubing from that, and the other part attaches right to the chest tube that's in the client. And this is where we would tape up and then tape down so that it doesn't become disconnected. The other tubing goes to the suction, and you will see the suction monitor bellows. It's red. And as you increase the suction, that little thing with numbers on it above that bladder will show you where you are, -20, -30, -40. Okay, down below, you're going to see the air leak monitor. Okay, and you will see the suction control chamber or suction regulator. Those are your components. So I told you, this is in for a while. So let's say the chest tube was put in and they came from surgery, and when they came to you in the ICU, you looked and you saw that they had 50 milliliters of fluid in that collection chamber. Take a Sharpie pen, mark it with the date and the time, and watch it. You don't want to see them dump 300 milliliters in an hour, do you? How are you going to know? Mark it as it comes in. Initially, after surgery, you may be marking this every hour, every 15 minutes. It depends on what's going on with the client. Now, eventually, this thing may get full. What shall we do about it? We're going to change it out. This is a 2-person job. Don't do it alone. Get your suction, your new one in there. Disconnect the existing one from the suction and have it ready to go on to your new one. You will unwrap your tape, And this is the only time that you will clamp. This is the only time you will clamp. This is the only time you will clamp the chest tube. Slip that blue clamp on, take the old drainage container off, and plug in the new one, and then tape, and away we go again. Now, there are water chambers or they are dry chambers. You have to see what your agency provides and which way they want to go. Okay, nursing assessment. Watch for your titling. It should be decreasing. That tells you that the pneumothorax or hemothorax is getting better. Watch for air leak. That's your bubbling in that water seal chamber. Make sure that if it's a water seal that you will fill it with sterile water. Okay, that's a piece of machinery. It's a tool that we use to help the patient. But don't forget, we need to assess our patient. What are their vital signs? Are lung sounds getting better? Keep ahead of the pain. I told you, watch your drainage amount. Check your sites for bleeding. If you see pus coming out, that's a problem of the drainage site. And subcu emphysema. They call this crepitus. This is an air leak under the skin. The worst case I've ever seen is when the shoulder area swelled so bad it went all the way up to the person's cheekbone. Okay, so what? It looks funny? No, there's a lot more to it. Think about what that air is pushing on. It can deviate the trachea. It can push organs in different places. So subcutaneous emphysema tells you that you have an air leak, but it is under the skin. Outline it. If it happens, it should go down. When you press on it, it's going to feel like Rice Krispies underneath the skin. Now with the chest tube, we still want them to deep breathe. We want them to move. And yes, use the incentive spirometer. You may have to pre-medicate them for this. Milking or stripping of chest tubes, not recommended. What is it? Well, if it's a hemothorax or they've come from open heart surgery, blood is coming out of those chest tubes. And last I knew, blood will clot. So they used to have us milk chest tubes. Surgeons will still do this. But what they would have us do is put lotion in our hands and just press down on the chest tube, hold it steady, and strip it. Just run your fingers down so you break up that clot and it goes into the collection. That's all you're trying to do. But this is not recommended for some very good reasons. It can increase the interpleural pressures and it can actually do some damage to the lungs. So the big deal here is make sure you know where your tube is. Don't let your client lay on it. That's going to prevent the fluid from draining. Okay, curl it in a light circle and then have it come down to the chest tube and the chest tube collection device. Now, can you move people with chest tubes? Yes, you can, but be careful. Sometimes in moving them, you will hook them, you will unhook it from suction, and then that is called water seal. It's still maintaining the negative pressure. And you would only do this if they were stable enough to allow that to happen. You would take that container, it has little handles on it, and hook it to the bed for transport. When you're moving, things will slosh. So your measurement markings may be off. You need to assess them again to be accurate. Okay, we're going to talk a little bit here about lung cancer. It's a leading cause of cancer-related deaths. Take a look at how many new cases come in every year, and it has a very high mortality rate. But with surgery, with chemo, with radiation, things are getting better. They're finding out more and more about the different types of lung cancer. Is it oat cell or is it large cell? Smoking has a high link to lung cancers, but so does asbestos. So does working in areas where they have carcinogens, okay? Because it's actually altering the lung tissue. And what is cancer? Altered tissue, okay? With this particular semester in mind, with COVID, if people have pre-existing lung problems like emphysema, COPD, asthma, They seem to be at a higher risk for having COVID there. So lung cancer is like all cancers in the fact that we are going to treat it with surgery, with chemo, with radiation, all three, or maybe just one, maybe just two. All right, this is lung cancer. Kind of pretty picture, isn't it? The black pigmentation is not normal lung tissue. See the big tumor in the other picture, that big white? Do you think any oxygenation is going on there? None. So what is our assessment for cancer? Cancer's got all those lovely 7 signs. Do you have a cough? Are you coughing up blood? Have you had weight loss? Are you extremely tired? Is there a change in your voice? Are you hoarse? Has the timbre of it changed? Is it difficult for you to swallow? Are your lymph nodes involved? Are they enlarged? Okay. Other things, ask about a family history. Is there a family history of cancer? Do you smoke? Do you vape? What do you do for a living? What do we want to do with all of these lung problems? We want to achieve an effective breathing pattern, maintain an adequate airway clearance, make sure we get decent oxygenation, as comfortable as we can get them, and have an understanding of what our treatment is and how long they're going to be there. What is the prognosis, okay? In lung cancer, the big thing is to do symptom management. Do a lot of teaching, okay? Monitor for side effects of these medications, for sure. Coping strategies for it. This is a scary disease. And then know what resources are available out there. Okay, there's your lung cancer treatments. Now, radiation therapy, you know what that is, surgical therapy. Do we take out the tumor? Do we take out a part of the lung, a wedge resection? Do we take out a lobe of the lung? Do we take out the whole lung? A pneumonectomy. Can you live with one lung? Yes, lifestyle will change, but you can. Radiation therapy, they will have tattoos placed to the area where they want to beam it. And then the person shows up for the radiation therapy. Now, what do we watch for there? Think about it a minute. Can they become sick, nauseous with it? What about the skin? Do they get burns? Can they? Absolutely. So skin integrity. Stereotactic radiotherapy. This is guided. They actually will put little rods in the area to guide the radiation to. Chemotherapy. You know that chemotherapy doesn't just go to the cancer. No, it shares its wealth throughout the whole body. So we have all these side effects that people can have from chemotherapy. They can get mouth sores. They cannot want to eat. They can have severe nausea. They can have vomiting. They may lose their hair. So how do they feel about themselves? They may become neutropenic because chemotherapy attacks everything, their immune system included. So they are at a huge risk for a compromised immune system and opportunistic infections. Targeted therapy may be electron beam. It may be, again, these may be the pellets that they put in. They may decide to take, there is something called, it's a radiotherapy that they do in radiology, and they can either put a freeze ball of ice around a tumor, or they can fry it. Cryoablation or radiofrequency ablations. Those are 2 different things that they can do for different tumors too. And then immunotherapy is the new one, the hot off the press one, where it is specific to you. They match the DNA of your tumor to the most effective treatment. TGen is one of the companies that does a lot of research with this. Okay, your diagnostic studies. Pretty simple. Anything to do with the chest, right? Chest x-ray, CT scan, We want to know what's going on inside the lung, so let's get sputum and send it off to see what's growing. They may do a lung biopsy always if they're thinking cancer. This can be a fine needle aspiration, or they may have to go to surgery depending on where the tumor is located. Or they may tap this person and pull off pleural fluid and see if they see any cancer cells in the fluid. Now, why would they do a bone scan? Why would they do CT scans of the brain, pelvis, and abdomen? We want to see if this is metastasized. Cancers do metastasize. Where have these cancer cells migrated to? A CBC with differential. Let's see what their immune system is doing. Let's make sure that they have adequate hemoglobin and hematocrit, that they're not anemic. Chemistry, yes. Not only will the cancer mess with electrolytes, but the treatments will. Again, for the same reason, liver, renal, and pulmonary function tests. An MRI, maybe they can have an MRI, maybe they can't. There's a screening for that. Do they have metal in their bodies? An MRI gives us a look at the whole area very, very closely to see if there's a problem. And a PET scan, positron emission tomography. They are injected with the radionucleotide mixed in glucose. And it goes, cancer cells, tumor cells love glucose. So those tumor cells say, come here, glucose, and the uptake is there. Then they scan them in radiology, and that area will light up and tell them that they have white spots here, they have white spots there. It gives them an idea of how advanced this disease state is for this particular client. If they're a diabetic, they will have special treatment because their glucoses are higher. Okay, on to the thoracotomy. This is a surgical procedure, incision into the chest cavity. These things hurt. These people will be in pain. They may do a wedge resection, meaning they will cut like a wedge of the lung out. They may remove the tumor. They may remove a lobe. They may remove the whole lung. Okay? So you can have a lobectomy. You may have a pneumonectomy, and you may have a video-assisted thoracic surgery. If at all possible, that's what they do because it is less invasive. You're using a camera. You don't have the big incisions, and the patient has a faster recovery. So post-operatively, I told you again, pain. Yes, they will have chest tubes. Watch them for respiratory distress and effort. What is their respiratory rate? Are they using extra muscles to breathe? Are they trying to sit in a tripod position? Are they puppy panting? Are they breathing real fast and short? Yes, we do x-rays, and not just daily, it may be every 4 hours for a little while. Now with pneumonectomies, if they take out that lung, that empty vault in the chest cavity will fill with fluid. And people, I've had them say, I feel like I'm sloshing when I walk. They will eventually get used to it, believe it or not. Okay, lung transplants don't happen for just cancer. They are indicated for end-stage lung disease. Cystic fibrosis should come to mind here. Cancer. Okay, in one lung versus the other. But there are some absolute contraindications to somebody going for a lung transplant. If they've had a recent cancer in the last 2 years, if they have chronic active hepatitis B, HIV, if their kidneys or liver are in failure, if they haven't stopped smoking, if they have so many comorbidities that they will not be a good candidate, or if they're not going to be able to manage the care that they need post-transplant, anti-rejection medications. Okay? They will, before they have a lung transplant, they go through a whole barrage of testing, and psychological testing is one of those to see if they're going to be able to handle it. So stop and think about why these contraindications exist. If they have a recent, within 2-year malignancy, a new one pop up, is it going to do any good? Chronic active hepatitis B, why? HIV, why? Does this have something to do with their immune systems being messed up, compromised? What about liver or renal failure? Do you think that the medications that they will have to take can further damage these organs? Yes. Okay. Post-op care, lung transplants are in ICU. Yes. Hemodynamic monitoring. Oh my golly. Art lines, EKGs, probably a pulmonary artery catheter, non-invasive blood pressure if they don't have an art line. I's and O's, massively so. We want to do cardiac output, cardiac index, because remember the relationship between the heart and the lungs. Fluid and nutritional support. Okay, if they don't have adequate nutrition, they will not heal. So, is this person a candidate for a tube feeding? Is this person a candidate for TPN or PPN? Do you think that you should call in another member of the healthcare team, like the dietitian or it would probably be your dietitian, to determine their caloric needs? Maybe they can go on tube feedings, but what kind? How many calories per day are they going to need? You can't figure that out. So you'll have a consult, and they will come in and work with the physician to determine the best formula. Maybe they're not a candidate for a tube feeding. Maybe they can have a PEG tube. Maybe they can have a GJ tube. Or maybe they do need to have a central line or a PICC line placed so that they can have TPN. Immunosuppression. So what are you going to watch for? Well, what are their white cells looking like? Take a full look at a CBC. Look at the indices. Do they have mature white blood cells or do they not? What is their temperature? Is it low? Is it high? Detection of early rejection. How do we know it is happening? All right, well, if it's a lung transplant, their labs are going to be skewed for one thing. They're probably not going to be breathing very well. Their PEFR is going down. So what the doctor will probably do is get a lung tissue biopsy and see if they're rejecting it. Infection prevention is massively important for this client. They will wear a face mask at home until their immune system is built up enough to handle things. They must remain on target with their medications, their immunosuppressants. They're usually on a triple one. One would be a steroid. One will be something like Cellcept, something like that, but anti-rejection medications. It's a lifelong regimen for them. These are some of the medications. They give them steroids as well. They must be aware, they must be taught to watch for rejection signs and symptoms. They can never miss a medication. In fact, they're instructed to have a watch with an alarm and to carry their meds with them at all times. So I hope this was informative for you, and we'll be talking about this in class as well.